It's not really a case?
It could be. Alright, so we'll get started.
I like that I'm in the front row. I know, she's
Alright, so I'd like to welcome our first guest here, Dr. Rich Lapin, our soon-to-be father of twins.
So they say. Thank you. Thank you. All right, a little discombobulated, so if anything doesn't make sense, blame it on the twins. Good morning, everyone. This is case follow-up, and it's a little bit of a twist. It's more of a rant than a case follow-up this month, but there are cases, so it's not a complete lie. So what I'm going to talk about today is what I call the hypertension mess and how it got that way. So I'm going to be, some of you who have worked with me over the years know that this is a particular obsession of mine. How we think about hypertension and how we treat it in the emergency department and why I think we get confused about it. And like many of the things I'm interested in now, it kind of started during my residency. I was an IM resident. And there were things that didn't make sense to me as a resident. I find I'm still kind of perplexed and interested in now. And one of the many things that I didn't understand and didn't make sense to me then was how we treated patients who came in with high blood pressure. So this was a little before the stroke thrombolysis era, and I remember we would get stroke patients as admissions, and my resident would say to me, "We got to bring that blood pressure down now." And I would think, okay, why are we doing that exactly? And he or she would say, well, stroke is a hypertensive emergency. And I think, okay, because it's caused by fibrinoid necrosis of vessels in the brain, and that's brought on by hypertension. And I think, well, isn't stroke caused by a thrombus in a vessel? How is bringing the blood pressure down going to cure that? So that's, if you fast forward to now, that's what I've been thinking about ever since. And that's what I'm going to talk about today. So here we go. Usually when I lecture, it's to tell somebody about an illness that they don't know much about, a new disease, or new aspects of an old disease. So what I'm going to try to do today is erase two diseases from your lexicon. I'm going to actually make your life, I hope, a little bit simpler. And those two diseases are what are called hypertensive emergency and hypertensive urgency. And the reason I want you to remove them from your list is because they don't exist. Hypertensive emergency is a kind of hybrid of two diseases that really do exist. Hypertensive urgency is kind of like a unicorn. It's a lovely idea, and it's very mystical and beautiful, but it also doesn't exist. So you really shouldn't be diagnosing people with it. Both of these terms, I'm going to try to teach you, are the results of a well-intentioned mistake made 3 decades ago in the 1980s, and sort of in 1984, auspicious year. And I think that 30-year-old mistake is why we treat hypertension differently than we treat all other cardiovascular risk factors, and why we treat it in ways that don't make sense. So, to talk about hypertension, I'm going to need the concept of alternate worlds. This is our world. Lovely. Some of you may remember in the old Superman comics, there was the Bizarro world, which was I think it was actually cube-shaped, and it was the opposite of our world in every way. The good was bad, and bad was good, and ugly was beautiful. So I'm going to talk for a minute about what I would call the Bizarro cholesterol world. And it's an alternate world, very much like ours, almost identical to ours, except for one big difference. In our world, as you guys all know, people obsess about their blood pressure, and patients come in at 2 in the morning to the emergency department because they got up in the middle of the night and they didn't feel well, and they went for the blood pressure cuff and their BP was high. But in the Bizarro cholesterol world, people obsess about their cholesterol. They all have little home point-of-care cholesterol monitors. These exist, by the way. That's an actual cholesterol monitor, and you can prick your finger the way you would for a finger stick glucose and find out your cholesterol 24 hours a day, at home, at 3 in the morning. And In our world, people don't do that, thank God, because then we'd have to deal with them too at 3 in the morning. But in the bizarro cholesterol world, they do. And patients wake up in the middle of the night, they don't feel well, they reach to the bedside table, they pick up the cholesterol meter, they prick their finger, they find out it's 250, and they call 911 and come to the emergency department. It's a great world to live in. So let's talk about how people think about cholesterol in the bizarro cholesterol world. So we all know in both worlds that cholesterol is a risk factor for atherosclerosis. It's a risk factor for arterial vascular disease, and it can lead to all kinds of bad complications like myocardial infarction. That we believe in both universes. In the bizarro cholesterol universe, people believe that what happens to you moment to moment is the result of your cholesterol at that moment, causing the disease that you have at that moment. Everything is cholesterol if your cholesterol is high. So, in the bizarro world, a cholesterol over 250 is called a cholesterol crisis. That's just the way it's defined. So if you have a cholesterol of 263, some of you may, you have cholesterol crisis as we speak. Now, all the practitioner has to do is decide which, this is my little lipemic serum. This is supposed to be high cholesterol. What you do as the physician when the patient walks into the emergency department and says, oh my God, my cholesterol is 275 and I feel a little tired, you're supposed to decide what version of crisis they have. And there are several possibilities. If they feel great, if they're just there because their cholesterol number was high, they have what's called cholesterol urgency. Okay, fine. And they need to be treated with a statin to reduce their cholesterol, but you've got like 24 hours to bring it down because it's not that bad. If they have, here's where it gets tricky, if they have the symptom of one of the complications of high cholesterol, let's say they have chest pain. Chest pain could be an MI. MIs can be caused by high cholesterol along with other things. If they have a symptom and you work them up, you get a couple of troponins, you get a couple of EKGs, everything looks great. In our universe, we would call this non-cardiac chest pain, right? Person comes in with chest pain, you work them up, nothing found, they're okay. But in the bizarro cholesterol universe, that's a symptomatic cholesterol urgency, right? Because they're in crisis, they have a symptom, it's got to be caused by the cholesterol. There's no other possibility, right? And so they have symptomatic cholesterol urgency. Actually, I can tell you in a minute, I actually saw a patient last week who was diagnosed with this by his PMD, amazingly enough. So the two worlds are actually starting to bleed into each other.
A cholesterol urgency?
Basically, yeah. Yeah, I mean, he had, just digression, he had what I thought were panic. Like a 30-year-old healthy guy with high cholesterol. He'd been having very atypical chest pains and shortness of breath and palpitations and anxiety that I think was panic disorder. His entire workup, you know, two tropes, blah, blah, blah. It'd been going on for months. Was negative. He went to his, he'd gone the week before to his PMD, and his PMD, he said, what is this? And his PMD said, it's because your cholesterol is high. Take a statin and come back in 4 months. So this is not so crazy. Well, it's crazy, but it's being done. Okay, so that's urgency. What happens if you actually have a problem? So let's say you feel okay, but you go to your doctor and your doctor gets you an expensive coronary CT and you've got coronary calcification, you've got coronary artery disease. Well, in this universe, that's target organ damage, right? Because the coronary arteries are a target organ for high cholesterol. That's what it does, is causes arterial plaques. So you've got target organ damage, so by the rules of this universe, you have what's called cholesterol emergency. Asymptomatic, but nevertheless you need to be treated immediately, like everyone else, with a statin. And finally, if you have a symptom like chest pain, and you actually have the acute complication that we're worried about, like let's say you actually have a STEMI, then you've got a symptomatic cholesterol emergency, and the treatment is, the most important treatment is statin, of course, because it's caused immediately by the cholesterol at that moment, and so you need to start a statin immediately. And maybe get an angioplasty too, I don't know. But the statin's what's really important because everything is caused by the cholesterol. Any questions about that in case you find yourself in this alternate universe tomorrow? You wake up and You're actually there? Okay, so everything is a statin. So this is, I would say, this is how we think about cholesterol in our universe, or how we should, right? So there's, everything happens in stepwise fashion. There are a chain of causes and effects, sort of like a race where one person hands the baton to the next and off they go. So high cholesterol is real. High cholesterol is a risk factor for arterial disease. High cholesterol goes on for many, many years. But it doesn't really cause damage, at least not that I'm aware of, immediately by itself. It causes gradual damage over time, and the gradual damage is atherosclerosis in large arteries mostly. And eventually you sort of tool along. You may have other risk factors. You may have diabetes, you may have smoking, other things in the mix, but eventually you get an acute complication. Now the acute complication is sort of a result of the cholesterol in a sort of stepwise fashion, but it's probably not triggered by your cholesterol at the moment that you have the MI. I mean, it could be, but it probably isn't. And it's treated very differently. Like we give statins to people with acute MIs. I'm not really sure what the data for that honestly is. It seems like a sort of version of the bizarro idea that because cholesterol caused your problem, we're going to give you the statin right now. But in any case, the way you treat it, the acute complication in this case is a thrombotic problem. It's thrombosis of an artery and needs to be treated with something that gets rid of the thrombus, angioplasty or TPA. So just because your cholesterol of 300 might be the original actor that got you in trouble doesn't mean that lowering that is the way you take care of the acute complication 20 years later. Does that make sense? It would be nice if the world worked that way, our world, but it doesn't. You know, it'd be nice that if you could treat everything by treating the underlying cause. But after a while, you get damage accumulating and you have to treat the subsequent complications. So, I would say everything we know about hypertension indicates that it pretty much works the same way as cholesterol. There are some subtle differences, but it's pretty much the same thing. So, hypertension is a risk factor for lots of things, including arterial vascular disease. It goes on for many years generally. It can go on for decades, go on for a lifetime. There's gradual damage. One of the problems is atherosclerosis. There are others. And eventually, down the road, you get an acute complication, which could be MI, could be congestive heart failure. And those acute complications can't really be treated by treating the hypertension. A few of them can. So what acute complications of hypertension include what? Things people come in with that are related ultimately to the fact that they've had high blood pressure. Like a syndrome, a disease. For example, stroke, yeah, okay. Reduce the blood pressure? No, probably makes it worse, right? That seems to be what the latest data indicates. If you drop people's BP when they have an ischemic stroke, you probably make them worse, right? Permissive blood pressure control. MI? Never been clear to me that there's any data for reducing BP in acute MI. You'll see articles talking about it all the time, and I've never been able to find a data source for any of their claims. I've read articles talking about what's the best agent to lower BP in the setting of acute MI. There's no evidence base. They don't refer to any clinical study. It's kind of bizarre. Aortic dissection, yeah, there you do get a benefit by dropping the BP. Hypertensive encephalopathy, yeah. Some yes, some no. But in the main, pulmonary edema, yeah, if you decrease BP, decrease afterload, you get a benefit, yeah. So sometimes yes, sometimes no. It's not automatic. It's sort of on a case-by-case basis. But really you have to decide what's going on physiologically down the road with the complication. Okay. So there's no sort of unitary syndrome of complications, all of which are caused by sky-high BP at that moment. But nevertheless, turns out we live in a bizarro world. We live in the bizarro hypertension world. We didn't realize it, where we're basically doing the same thing with hypertension that the bizarro folks do with cholesterol. So we've divided hypertension into urgency and urgency into symptomatic and asymptomatic. and then emergency into target organ damage and acute problems. And this is just as irrational as it is in the cholesterol world. It really doesn't make physiologic sense. But you'll see it all the time. If you pull up an article on Medscape or Mayo Clinic, you pull in their website, you will see exactly this. Symptoms and no sign of any organ damage is symptomatic hypertensive urgency. Completely imaginary disease. Or target organ damage and the person feels fine, it's an emergency because they actually have damage from their high blood pressure. Okay. So the question is why do we treat these things so differently? Why do we treat one risk factor very casually? If someone came in and said to you, hey doc, I'm really worried because my cholesterol is high, you would probably say in the ED, okay, see your doctor, talk about starting a statin. Like, okay, fair enough, you can go home now. But if they come in saying my blood pressure was 200 at home and I'm really worried, we start giving them meds, we start putting in IVs sometimes, dropping their blood pressure, checking all kinds of labs. Why do we treat these things so differently? And I think to understand that, you have to kind of go back to the history of our understanding of BP and how to treat it. So I'm going to do a little historical romp through the exciting history of blood pressure. I find this stuff fascinating. You guys may or may not, but I think it's actually kind of cool. And it sort of helps understand why we've come to the place we are. So let's go back 100 years, 1916. This is Times Square in 1916. Well, kind of a busy, raucous place. Looks a little bit different now. Many more tourists, many more tourists. So 100 years ago, during the time of the First World War, it was already pretty clear to physicians that hypertension was a bad thing, that it was associated with bad outcomes. And some of them knew this from their personal experience, but really where the data came from was from the life insurance world. Life insurance actuaries who tabulate people's death rates and look at their death rates with certain pre-existing conditions, realized pretty early on that if you had a high blood pressure number on the fairly newly developed sphygmomanometers that had just become available, if you were consistently high, there was an excess of death in that population. People died earlier. So the life insurance people were on it immediately because it was very important to them. The physicians were, I would say, considerably more relaxed about it, and really for three reasons. First of all, and you guys know this, clinicians I should say, were aware that most people with high blood pressure ticked along perfectly fine for years and years and years. I mean, you may have friends or relatives, whatever, who had hypertension for 20, 30, 40 years. They're fine. And that was clear even before people were treated with antihypertensives. It was clear that most patients who came to the doctor's office year in, year out with elevated BP, they're fine, and they lived their lives. Maybe they were living shorter on average than people who had normal BP, but it wasn't a big deal. So that was reason one. Second of all, there was a lot of controversy about the meaning of high blood pressure. There was a very prevalent theory at the time, which is not totally crazy, that hypertension is compensatory, that the real problem is narrowing of peripheral arteries, and the BP is high as a way to drive pressure through those arteries. So there was a great deal of concern that if you could drop people's BP, and that was not so obvious that you could, you'd actually harm them, that they needed it. And then finally, the third reason that nobody paid much attention to high BP is there was nothing you could do about it. That's a pretty good reason for not getting too worked up about it. Hope you can see it. Here's a little clip from a textbook of the time, internal medicine textbook of the time, and they say drugs do have a place in the treatment of benign hypertension, and it's really all about constipation. I had to look up what blue mass is. They recommend a dose of blue mass every week or two. It's a sort of weird amalgam of herbs and mercury that was used. It was used as an anti-constipation agent. Apparently, it was very popular in the British Navy, where sailors didn't eat a lot of roughage, so they would get their little tablet of blue mass. But basically,
You know what unanim was?
huh?
But you knew what unanim was? Next.
No.
Mass, but you never looked up unanim?
Yeah, I don't. God only knows. So yeah, all of this was about taking it easy, getting enough sleep, living a healthy life, and moving your bowels regularly. Because that was really all there was. There were some very early studies of very severe sodium restriction around this time for hypertension, but we're talking about diets that sort of no normal human being could possibly contemplate for more than a few, like unsalted plain rice and water. That would bring your blood pressure down a little bit. But this was not a serious therapeutic possibility. So this was kind of the age of apathy. You know, you had high blood pressure, all right, that's not good, but come back and see me next year. But there's one tiny subgroup, this is not the planet Earth, by the way, there's one tiny subgroup of patients who really made clinicians want to intervene. And these were mostly young and middle-aged men with severe hypertension who also developed very severe retinal small vessel, small artery disease. So they developed what we would call hypertensive retinopathy. And in the retina, the reason that this became the key to the diagnosis is because in the retina you can see small arteries, you can see them every day. Just look inside the back of the eye. So this is where you could diagnose it. And they had, some of them, the worst off, had papilledema. Others had these cotton wool spots that you can see, sort of white patches, or flame hemorrhages. I think you can see a few of those at the top of the screen where vessels rupture and hemorrhage. These guys were not really well. If you read the case reports, which are kind of fascinating, they were sick, they had bad headaches, they lost weight, they were really kind of sickly, mostly guys, but women too. Sickly people. There was nothing obviously acute going on with them, but if you looked in their eyes and looked at the retina, you'd see that there was bad stuff going on with small arteries. And their prognosis, this tiny little subgroup, is terrible. This is a paper about what had come to be called malignant hypertension. Malignant because the prognosis was so bad. If you followed these patients, about half of them were dead in 2 months after diagnosis, and 90% of them were dead within a year. So kind of like a malignant cancer as far as prognosis, or like a bad malignant cancer like prognosis. So these were otherwise healthy, fairly young people with a horrific prognosis. Very tiny group. The estimate was maybe 1% of people with bad hypertension. That's never been clear. It's clearly not just high BP that selects these people, because most patients with even crazy high blood pressure don't go on to develop these small artery changes. Nobody really knows why some people do and others don't. Even a century later, we still don't really know why. What do they die of? They don't die of all of the complications of chronic hypertension, like MI and stuff like that. They tend to die of, now remember, this is before dialysis, so if you developed renal failure, you died. They developed renal failure, they developed heart failure, and they had strokes, especially hemorrhagic strokes. So those 3 diagnoses were sort of selected for in this tiny little subset. Here's 105 patients basically followed till death. One had an MI, one had a dissection, all the others died of renal failure or heart failure or stroke or some combination of those things.
The dissection had a stroke.
The dissection also had a stroke, yeah, from his dissection, presumably dissected up. So bad disease. And if you looked in the kidneys of those who died of renal failure, you'd see this very specific pattern of intimal hyperplasia, that kind of onion skin thing you may remember from medical school, onion skinning, and fibrinoid necrosis. There's also deposits of sort of amorphous material in the vessel wall. And that's sort of what you'd see in the retina if you took a look on autopsy at the retina. Same sort of small artery pathology. So this is a very different group from the vast majority of people with high BP who just kind of sail along feeling fine and then get a heart attack or get a stroke or some other cardiovascular complication. So in effect, these people with sort of so-called malignant hypertension really have a sort of they have a kind of subacute slow-moving complication. Sort of imagine that. So this is what happens to you with high BP. a few people will get this kind of slow-moving acute complication, subacute complication of small artery disease, and they'll kind of move more quickly to a devastating acute complication. For whatever, well, we can talk about why, but whatever reason, people don't talk, I mean, in the ED certainly, and in clinics about malignant hypertension and small artery disease. It's very real, but when clinicians, when PMDs send in patients with bad hypertension and they're worried about something, they're pretty clearly worried about that even if they don't know what it is. And I'll show you a case at the end of an example of that. And I remember this from residency as well. There's, you know, I knew there was like some bad hypertension thing with the eye and the kidney, and I knew you were supposed to like check the creatinine, but I wasn't really sure why. Well, that's why. It's because of malignant hypertension that isn't really talked about anymore, but still exists. So that's where we were. We've gotten up to like the 20s and 30s, the middle of the 20th century. You had a lot of,
You can answer this question either historically or actually with people who develop what they were calling malignant, hypertension.
Yeah.
Was there any sense that their blood pressure had taken a recent spike up, that they had gone off of their curve, or are they just?
Not, you know, it's a great question, and it's not entirely clear. There, a lot of these, you sort of have this problem where when people are followed well for hypertension, then they tend to, nowadays, obviously they're treated, and in the days when they couldn't be treated, they weren't really followed that closely. There was an assumption that they had kind of accelerated, and people still use the term accelerated. But a lot of these patients, at least if you look through the early case reports, showed up at the doctor feeling crappy, and their blood pressure was like 250 over 150. And who knows how long they had had it, because this was an era where routine screening was not done for the most part, because of that sort of casual attitude toward it. So it's not entirely clear how rapidly these people, there's often an assumption that they accelerated dramatically, and again, that's not entirely clear. Probably they do. All right, so mid-20th century, we've gotten to there long before you're born. Large group of people with so-called benign hypertension who everybody's kind of ignoring and not making much of. And then this tiny group with so-called malignant small artery disease who have horrific prognosis, but there's nothing you can do about them either until the 1940s. And things began to change in an important way. You now had the development of drugs that could reduce blood pressure. And these are the ganglionic blockers that Dr. Rao probably knows well as a toxicologist, but none of the rest of us really deal with. Tetraethylammonium, hexamethonium, trimethopam. I've never used any of these agents. I don't know if anyone uses these agents at all, except for maybe very specialized circumstances like FIOs or something in the OR. But they block cholinergic transmission at autonomic ganglia. So you basically shut down the sympathetic and the parasympathetic nervous system. And in the 40s and into the 50s, you started seeing these agents used to try to treat that really bad prognosis group of malignant small artery patients, the young men who were dying, you know, within a year of diagnosis. And the amazing thing about these drugs is they actually worked. So untreated patients, survival curve, treated patients, survival curve. Not great, but first demonstration that you could actually save these people's lives if you reduce their BP. This is from the mid-50s, I believe. So that was the good news. The bad news is these drugs are horrific. They're kind of the equivalent of taking cancer chemotherapy. A lot of them had to be given by injection every day. The autonomic side effects, you got every autonomic side effect you could imagine. The patients in these studies had to get special glasses because they couldn't focus their eyes. The men, of course, all developed erectile dysfunction, which made them very unhappy. Everybody got orthostatic hypotension, so if they stood up too fast, they would pass out. They got constipated, they got urinary retention. It was presumably awful. But it was the only alternative to dying within a year, and so some people were willing to do it. Really, you wouldn't be able to tolerate a regimen like this unless your alternative was death. And maybe for some of the men, that was the better alternative, I don't know. But fortunately, the drugs got better. So once you reach the 1960s, spacewalk. You had reasonably tolerable drugs that you could add on. So you had the diuretics like hydrochlorothiazide. You had MAO blockers like reserpine, which made people depressed, but okay, hydralazine. And so in the 60s and into the 70s, public health officials started to think, hey, we can save these people with malignant changes. Now what about the 99% of the hypertensive population who we've sort of ignored? Could we start treating them, and would it make a difference? And there was a lot of resistance to this in the medical profession, actually, a lot of skepticism. There was actually, interestingly enough, skepticism that this was a big pharma initiative to get everybody on BP meds, which I hadn't realized was an issue that far back. But there was also a sort of skepticism that this would work. There was still a lot of belief that hypertension for most patients was compensatory, and that you messed with compensatory reactions at your own peril, that you would actually make people worse if you started to bring their blood pressure down. Again, not a crazy idea, but it turned out not to be true. And the turning point was this, anybody know about the VA cooperative study? Like amazingly famous study. So this was done in the mid-60s, and this was the first study to really demonstrate that people with non-malignant blood pressures could be treated and that it would save their lives. It's kind of amazing. Like, we were preparing to put a human being on the moon, and we were still trying to decide whether it would be beneficial to treat hypertension. Kind of a bizarre conjunction. So these were veterans, this was the VA hospital, with crazy high blood pressure. So we're talking, in this first study, diastolics of 115 to 130, which in the world today would make PMD's heads, they'd go berserk, they'd call an ambulance, they'd send the patient to the ED. In this case, they were randomized to a controlled group or a treatment group. They were put in the hospital for a few weeks to see what their blood pressures were kind of at baseline, and then they were treated or not with hydralazine, hydrochlorothiazide, I think, and reserpine. And the results were quite dramatic. There were about 27 bad outcomes among about 70 untreated men, and 2 bad outcomes in the treated and 70 treated men. So that was just amazing. But again, there was so much skepticism that this study got very little attention for several years. It took years for this to kind of percolate its way into the medical world because there was such resistance to treating hypertension broadly. But eventually, a huge public health campaign to get everybody treated. There were all these kind of slightly cheesy posters, but the intention was good. The intention was to get people screened and get people treated, and prevent all of these preventable complications. The Joint National Committee on the Detection, Evaluation, and Treatment of High Blood Pressure, a very sexy committee, was formed, usually abbreviated JNC, Joint National Committee, and they started publishing every few years updates on how to treat hypertension. And basically, this was revolutionary. The revolutionary idea was that everybody with high blood pressure should be treated. Millions and tens of millions of Americans should take a daily medication to treat something. And this was, again, there was tremendous resistance to this, but this was